Hello and welcome to another Polestar Hour. Today I'm super excited with some very special guests, sort of heroes of mine in the physical therapy world and particularly in education, and really focusing on what we talk about in Polestar all the time is evidence-based sciences that support the activities that we do as movement practitioners and physical therapists and Pilates teachers. So super great to have Dr. Adriaan Louw and Dr. John Childs on with us today. We'll be talking in just a few seconds. Many of you have heard me talk about both of these individuals in the past. A lot of times I'm talking about pain and chronic pain, and I have quoted Dr. Adriaan Louw in his book quite often about the importance of education, and in particularly how we can tell the story of others and things that allow the patient to understand, interpret, relate to. And so I really appreciate Dr. Louw's work. It's been a great contribution. My dissertation 20-something years ago was also looking, and we were actually looking, Adriaan, looking at the physical limitation measures as predictors, but
we'll be right back. I think Brent's connection dropped for a second. While we're waiting for Brent, would you guys like to say a little bit about yourselves?
Yeah, I'll probably get started. So Adriaan Louw, I'm a physical therapist, pain scientist, author. Work for Evidence in Motion, which is basically an educational organization dealing with post-professional as well as a pre-professional education, which John can speak to as much. I think the easy answer is I am a therapist. I've been a therapist for 30 years, moving away from clinical work towards pain science. And I think I find myself in the last so many years just, primarily working in the world of pain science and research. And then at Evidence in Motion, I play a big role in some of the curriculum we design for our post-professional training for healthcare providers. So, John?
My name is John Childs. I'm a physical therapist by profession as well. Spent my first few years in clinical practice, and then had an academic career. Did my PhD at the University of Pittsburgh, and did a lot of research for a while, and then was founded Evidence in Motion, and I'm part of a number of outpatient physical therapy clinics around the country. And spending most of my time these days working with our university partners. We come alongside schools in launching hybrid pre-licensure programs for those that are aspiring to become healthcare professionals in different disciplines like physical therapy, occupational therapy, and other rehabilitation-oriented disciplines.
Thanks, guys. Why don't we wanted to get a few questions to get an idea of everyone who's joining us. So how would you classify your profession? So we'll give you guys a few minutes to answer that question, and I'll put in the code in the chat. I'm also seeing some answers in the chat. So there's some PTs, some instructors, and let's just take a look at results here. It looks like we're halfway, right? We're in between. Hey, welcome back, Brent. We were holding the fort here while your computer decided to start in the middle of the session.
Oh my goodness, it's never done that before.
It's never happened. So I'm gonna go hide again. I'm gonna go hide again. Bye, guys. Well, I'm here, but yeah.
Thanks, Melissa. All right, so how many of these have we gotten through? First one. All right. So I'm assuming that John and Adriaan, you both introduced yourself and finished that off.
Good.
I apologize, everybody. I did want to say another thing with John that I had mentioned before, and I first met John when he was helping Lisa Stoltz, one of our lead educators in Polestar, and dear friend of mine, with her dissertation and her dissertation out of Rocky Mountain. And that was one of the first Pilates studies that was done that really looked at predictive values of Pilates. So thank you, John, for that. It looks like we have a pretty good mix here, right? On this list of people that are healthcare professionals and movement practitioners. Let's go to the next one, Melissa. let's keep that going. I'm also looking at people who have joined us. So the next question is, I've greatly benefited from the following. So take a second and answer this, because this is what we're going to be talking about today, is how do we make ourselves great and continue to grow in our professions, and what kind of things are out there that help us with that. So if any of these things have benefited you, take a moment to fill those out. And while they're doing that, so Adriaan, on the and did you guys talk at all about evidence in motion?
Yeah, we
Just a little bit, we did.
Let's take another little bit of just one of the questions I have is what was the catalyst for evidence in motion to evolve and to become the organization that it is today? And what sort of the vision and mission of evidence in motion?
Sure, I'll take a first stab at that one. So EIM was really born out of really my time as a PhD student at the University of Pittsburgh. I had the privilege of being mentored by some of the foremost physical therapist researchers, and was publishing a lot of papers, writing a lot of grants, but starting to feel a little bit removed from clinical practice. I had always really loved clinical practice, and I felt like I was living in an ivory tower, sort of thumping clinicians over the head with data. And you quickly realize that clinical practice is really hard. There's a lot of reasons for why rehab professionals use certain interventions or not, and patients in the clinic don't show up on time, like patients in lab studies and those sorts of things. And so EIM was really born out of a desire to connect sort of academics to clinical practice and provide educational resources in an online format to assist clinicians in sort of translating, if you will, best evidence into clinical practice.
Yeah, and I think that's what I'm most impressed with, John, is the idea of the practicality of it. And all of us have been through a PhD program. We've been in academia. We all have our share of teaching in universities, and yet we all have clinical practice. We all continue to do what we love, working with patients. And I felt like, how do we, in this particular webinar, how do we really help practitioners to continue to evolve and to be the best they can be? And Adriaan, I know you think a lot the same way, and are I think vice president of faculty development with Evidence in Motion. Is that right?
Correct. Yeah, I drive a lot of our content as well as training of our faculty. Correct.
And with that, like, what are some of the things that have motivated you with I mean, I know you hang around with some great people, the Lorimer Mosleys and the David Butlers of the world, and sort of tying in with some of the biopsychoneurophysiology things that have just really blossomed. But you bring an incredibly practical approach that is accessible by patients. I think that's something both of you philosophically feel strong about. Tell us a little bit about just sort of your philosophy and vision of why you went that direction of really the storytelling and in educating us as practitioners how to use that to really communicate with a patient, instead of having that condescending, this is what it is, I'm the authoritative one, you're the patient. You've really shifted the gears on that.
Yeah, I mean, you mentioned it there. I've been very privileged. I've been trained by the best in the world and have had exposure of some of the coolest people on the planet. What was very interesting for me is, I learned about pain neuroscience, how it works, but there was always the classic problem: what do I do Monday morning in a clinic? And I found myself, Brent, that, again, learning from these very smart people, how do I put it in a clinic? And dare I even say, I apologize to the audience. I know we have a multinational audience here, but how do I put it in an American clinic? Because we have fast-paced visits or whatever. And I think that's where the mojo happened, where okay, this is cool, but how do I do it in bite-sized pieces? And so we developed this process of just taking these bite-sized pieces of teaching people about pain. We know people learn through stories, metaphors, examples, not through factual information. And then if we tie it with things like compassion, empathy, therapeutic alliance, and they're not empty words or just things I'm spouting, it's absolutely vital, because we have to explain to somebody that pain experience they're going through. And we're sitting here today in 2022, and the research says it works. It absolutely works. If a human being in pain understands more about their pain and they can apply it to their issue, the problems they're facing, their life is better for it. And then that's one of our biggest driver has been to take it to the clinic, but help the clinician, but help the patient at scale here.
Yeah, and this is something that we've continued to build and incorporate your work, both of your work, and just the idea of evidence, of being able to really drill down and understand the needs of the client. And for example, from my perspective, I look at creating successful movement experiences. So, using things like imagery and proper tactile cueing to facilitate a movement that really does lead to the perception of a successful movement experience. So if somebody believes that pain doesn't allow them to participate, and all of a sudden you create a positive movement experience that looks a lot like the movement experience they just said they can't do because of pain, and they did it without pain because we created this experience, all of a sudden their paradigm starts to shift. And that was something we noticed, in a number of our research projects, of the more that they had that shift in the paradigm. And I think I see that so much with the storytelling, that they relate to a story and all of a sudden they understand and they comprehend, they can relate to it. And I think that's a big problem that we have all the way around. It's the same thing with our manual therapy skills and pelvic floor health, and the things that evidence in motion puts so much emphasis on our learning, is that when we know that 80%, for example, of people that have these particular symptoms, John, is going to likely get better. And for us to be able to teach them that as well as the expectation of the intervention we're going to do, like we're really, this particular manipulation, this particular exercise, this particular, re-education has an 80% success rate with people that manifest symptoms and symptomology like yours. And teaching the clinicians to be able to create that expectation as well. How do you, what are some things that you're doing in evidence in motion to be able to get to that level where the patient is understanding, that the practitioner is able to communicate correctly these things without sensationalizing, without catastrophizing, without, that's the worst disc herniation I've ever seen kind of talk, or you got scoliosis, it's amazing you can walk, but in reality, people with scoliosis have a lower incidence of back pain than people without, so maybe we should all want to have scoliosis. But how do you approach that in your program?
Yeah, well, I'll take a first stab at it, and maybe Adriaan can chime in, perhaps more specifically. But I grew up in the era of, as a physical therapist with manual therapy, where it was all about your hands and it was all about using the right technique, and things like patient education and those sorts of things. That was what therapists did who didn't know how to actually treat a patient, right? And that's a little, that may be a little extreme, but that's the sort of the analogy. It was all about the magic of your hands and the specific interventions that was going to be the formative contributor to a patient's recovery. And obviously, as evidence has evolved, that's proven to be not the ideal, sort of balance between the physical skills and then all of the, psychosocial and, verbal skills and patient education, in optimizing someone's thoughts around recovery to be very positive. That at least for most musculoskeletal dysfunctions, even if we do nothing, there's going to likely be recovery. And so just being able to shape a patient's perception is almost foundational to being to be able to use a physical intervention that then is incremental on top of that. So, bottom line is, 10 years ago, it was, 80% hands-on and 20%, perhaps patient education. And I would say that's fully flipped to where maybe it's 60 to 70%, shaping a patient's expectation around their pain, and 30 to 40% about the recipe, if you will, of the physical interventions that we utilize. Adrian?
Yeah, I want to go back. Sorry, Brent, but I want to go back to something that's I think is absolutely vital for your audience to understand. We don't explain pain out of people. This is one of the biggest fallacies out there, right? I sit with you, I teach you how pain works, but what it does, it reconceptualizes how you see pain. For so long, we've tied pain to movement, and if I hurt when I move, it means something's wrong and I should stop moving. I want your audience to 100% understand today the biggest change in pain we see is based on movement. Movement is the biggest painkiller on planet Earth. The problem is just people in pain won't move because they're fearful, they're catastrophizing. And we can alter that with some of these pain stories, metaphors. It basically, for a lack of a better term, gets them over the hump, the old, I'm going to be okay. Brent explained it to me, so now I move. And I also want people to understand, Dr. Unwinding is one of the smartest behavioral psychologists on the planet. And for a long time, he told me, he said, Adriaan, people don't have fear, which is ironic because he built a fear avoidance model. He said people lack safety. And it took me like 5 years to figure out what is it? Isn't fear and lack of safety the same thing? And it's not. When I look at movement science, it's providing a safe, encouraging, healing environment for people to move. And if they move without pain, awesome. If they move with pain, but they understand the pain, they're not afraid of it, so they're safe. And so, that I think it's critical for us to understand it's movement. John alluded to it, the part that we haven't covered. I mean, we started a small pain group that joined EIM. John acquired us in 2015, I think it was. John, I remember those days. But basically, the reason I was excited is because they took something that was magical that only a small group of people could do in special clubs and made manual manipulative therapy mainstream. Everybody can do it. It's no magic. We can all do it. And that's kind of the idea here. We should take it to the masses, to take it to our consumers. So anyway, but movement is an essential part of that recovery process.
And we, of course, love to hear that in a movement profession. So, and one of the nice things in particular in the Pilates is that we can manipulate load, right? So we can take that person that has that, and I love that analogy of more the idea of safety. And it's interesting you say that. I had a patient the other day, and she kept saying, I'm not afraid. But then she would use the word, but I think that if I could have changed that word for her, that it was just a matter of feeling safe. It's not that you're afraid, it's just that you want to feel safe. We could put it in a positive contextual way of wanting to feel safe, and that we can create that safe environment for you. So using things like assistive environments and manipulating load, or doing things that Peter O'Sullivan talked about, a graded load and return, and things that we've all been trained in. But how do we now create that environment? And I think there's like this perfect balance of looking at, we need to know how to talk to the patient. That's the behavioral side. Both of you mentioned it. We need to be able to communicate. I remember my first partner in business in Sacramento, California. And as you said, John, we both went through all the manual therapy. So we went through Kaltenborn, we went through Maitland, we did the Kaiser residency, we did all of Rockabato's work for TMJ and thoracic, and we did all of Dick Fike's work in Canada. I mean, we were consumed with learning every possible manual therapy technique. And Rob says to me at one point in time, he's like, Brent, I want you to take all the psychological patients, and I'll take just the ones that are manual therapy. Well, you can imagine what our practices looked like in 6 months. I was booked weeks in advance with full time, and Rob was seeing 4 or 5 patients a day that they still eventually came to see me just because of the idea that it was about communicating. It's about human beings. It's about, talking to them. And if I'm in a way that I can't talk to the human being, I can't discuss that expectation with them, we're not going to have the success. And that was the biggest lesson I learned in the early part of my career, was just how important it is to be able to have communication, and then to have the tools, as you're talking about, to be able to have the stories, to be able to know what expectations should look like, to know what the word even catastrophization or sensationalization mean, and how they still, I mean, I had a patient the other day that said, you know, the physician told them that, you know, the x-ray had, you know, degeneration in their spine of a 90-year-old, and they were 50 years old. And I had to show them some studies. I had to show them that what false positives look like, and that a lot of people have degeneration but have no pain, and it's just part of natural aging. So I think that's a very interesting approach that you're both, you know, we've all sort of come to agreement on, of how the psychosocial behavioral component is so huge. There were the two last slides, and Melissa, show this slide as well. This is just sort of giving us an idea of the pulse. It did show that there were a lot of people that were interested in the idea of some kind of movement residency and experience. And I think that the thing that we want to do is to collaborate in a way that we have, you know, John, your expertise in what you've built in evidence in motion, and Adrian's expertise in the neurobehavioral sciences and things like that, and our expertise in the movement science, and being able to create things that people are well-rounded. And that's really where we're going to be going.
Yeah, Brent, just one thought that came to mind based on a comment you made earlier. You know, as movement practitioners, we obviously function in an interdisciplinary sort of healthcare system, especially in, you know, the United States, and certainly in other countries around the world. And unfortunately, and I can't speak to other healthcare systems in other countries, but oftentimes, when, you know, the biomedical sort of focus in medicine still to this very day, even on the other side of the opioid epidemic, it's almost like less has changed rather than more. I mean, the rates of imaging for, you know, back pain that's very non-specific, and the patient's likely going to recover in 2 weeks, and yet they you know, they're diagnosed with this, you know, massive disc herniation. You know, we spend so much time, unfortunately, as movement practitioners, sort of unwinding beliefs that were sort of imparted to them by well-intended, you know, medical providers who were trained still in kind of the classic diagnostic model, where you're supposed to find what's wrong and fix the lesion, so to speak. And so, you know, it's just, we have to remember, you know, first of all, sort of do no harm, which is why it seems to me that as movement practitioners, our first sort of task is to understand the patient's beliefs and try to shape those in a as positive a way as possible.
Yeah. I mean, a lot of times I love using parts of the ICF model for that purpose. Like, I start backwards, where asking them, what do they believe they should be participating in, and what do they believe is not allowing them to participate at that level. And it's amazing. You know, Carol Davis talks about this in her interacting books of patient interaction, of just how many people, they know what's wrong with them, they just don't know how to say it. And our job is to try to help them articulate it. And it's surprising at what a patient will tell us of what they think is not allowing them to move in their belief construct. And if we don't address that, and we don't acknowledge that or re-educate that, then, you know, it's a tough battle. And that's why I think that old model you're talking about, the biomedical model, of we have to find that diagnosis. We got to find the MRI, the ultrasound. They have to show where this pathology is causing the problem. And a lot of these things would resolve on their own very quickly. There's a question that's up from Sarah Edwards. Hello, Sarah, from the UK. And Sarah is talking a little bit about, she's talking about the professional, and she says, I'm educated at doctoral level, so I know how to search for relevant and evidence-based information, but I think there is a gap in terms of how we support those who are new to the profession, and it's a minefield out there. And would love to have your thoughts on that. This obviously applies to physical therapy as well. There's just, you know, I have 2 calls that came in today from students from University of St. Augustine that are asking me, oh my gosh, help me, I'm graduating in 4 weeks and I have no idea where I'm going to go or what I'm going to do. And there's so many things bombarding them right now. of sort of looking at how do we help our students, our professionals out in the field explore and have the experiences that a lot of them we learned through hard knocks and through a lot of experience and hard work. But how do we, what do you see happening to be able to, at least in our professions of movement and therapy, help these practitioners understand better the models that are working out there? I mean, I think the other thing, John and a group of therapists made some monumental shifts in the way physical therapy is in the military physical therapy, and really shaped the whole diagnostic aspect of a lot of things we were looking at. And you know, I didn't even mention that earlier, but I think that was a huge shift in how we look at things like diagnosing, and the idea of letting the physical therapist do the initial couple of weeks of intervention or the healing time before they would even have an MRI, or before they would have a test that might not be warranted and cause catastrophization or sensationalization. I don't know if you want to comment on that at all, or either of you want to take Sarah's question on of how we deal with the new professional coming out.
I'll take a brief stab. You know, first of all, to your comment about, you know, the military healthcare system, you know, it's amazing what happens in healthcare when you sort of remove the financial incentives. The military health system is essentially a universal, you know, healthcare system. And so there aren't incentives to do unnecessary testing, and, you know, physicians, including orthopedic surgeons and others that specialize, there's not the turf battles. You know, it's really about trying to get the patient to the right place at the right time. And so certainly those models of what I think of as more progressive healthcare, you know, we need to find a way to replicate those models so that the patient shows up to the right provider at the right time. So much of, to me, you know, from my perspective, improving healthcare is about the process of care, and, you know, eliminating unnecessary paperwork and the burdens that come along with all of that. And so, you know, if we can re-engineer how patients show up to which provider at which time, you know, I think we solve, you know, half the problem. You know, in terms of the young, you know, professional, you know, from my perspective, it's really about trying to create an ecosystem that encourages lifelong learning, that, you know, yes, your entry professional training is certainly formative. It's what establishes the foundation for how you practice. But the reality is knowledge is evolving at a rapid pace. And, you know, if you're like me and you're, you know, 20 years almost out of physical therapy school, and you've not engaged learning in an ongoing way, I'm largely going to continue to practice exactly like I was trained 20 years ago, which was very well intended at the time, but half of probably what I learned has since been sort of disproven. And so you've got to create sort of cultures of lifelong learning.
Yeah. I'm going to spin on that, and I know Adrian's chomping a bit to talk. And I was just thinking of this applies directly to what we talk about in Pilates, gyrotonic, yoga, other movement forms, is that we have learned so much through the research. There's hundreds and hundreds of research papers now that have taught us that some of the things that we learned originally are not as effective as we thought they were. They don't belong inside of a novice patient or somebody dealing with certain pathologies. And if we don't take the time to learn those and to be able to integrate that new information into our practice, it puts us, we're actually putting some of our clients at harm, or at least not doing things that are actually going to help them get better. So, Adriaan, I know you were ready to go with something.
Yeah, I just want to, you know, specifically address a little bit to Sarah's question about research. First of all, there is an enormous amount of information out there, and what's scary actually for the young grad especially is what's on social media. And I'm probably gonna get a lot of backlash for this one, and that's okay. I know all the pitfalls of it, but this is what I do believe is what's the strength of evidence-based practice. there's a lot of opinions out there, and we can go onto Google, we can go onto any of these platforms. I mean, if you go onto these social media platforms where young students are hanging out, I sometimes get freaked out about the stuff they're discussing and the conclusions they're making based on, there's really no evidence. To Sarah's point, there are some databases. I mean, things like Pedro, Cochrane reviews that people can absolutely access. You know, there's a lot of opinions about a lot of things. One of the biggest advantages of evidence-based practice, and I know all the pitfalls, I get it, evidence-based practice isn't everything, but it gives us the North Star. For me, it is. I mean, I get inundated daily. Hey, Adrian, what do you think about this for pain, this for pain, this new device, do this. My North Star is always going to be evidence-based platforms and research, your meta-analysis, systematic reviews, etc. So, you know, for young kids that graduate, the answer would be to find those. There are those out there. And then with all this noise, to always go back to what's the fundamentals of evidence-based practice. And by the way, if you're a practitioner today of whatever you do, and that's fine. My strength is pain neuroscience education. If there is a gap in your approach, then study it. I mean, in 1996, I started teaching with David Butler, and neurodynamics, neural tension was not that great. I'm sitting here today in 2022, and I'll give kudos to the neurodynamics people. They've been putting a ton of research into it. Is it groundbreaking? No, but it's getting better. Michelle Computer's work, Shacklock's putting some new cool stuff out. So if you're in an approach that is emerging or not studies as much, doesn't mean it doesn't work. It just means you need to own it and then put some research behind it to prove, you know what, this thing actually works. And so, Sarah, to your point, I'm worried about the noise, the social media noise, because I do think we owe it to our patients and the professions that we represent, and our, ultimately to do what's the best thing for that approach. Otherwise, we're going to get back to where we were 20, 30 years ago again. So anyway.
You know, I have such a good example of that, Adrian. I changed my whole life, right? I had a practice in Sacramento, California, and I had a couple mentors that were bugging me that I needed to do a PhD. And I was really studying a certain topic where it was sort of like the psychology side or behavioral psychology side of chronic pain was saying that it was sort of a diagnose adios, that if you scored really high on your self-efficacy scores or fear avoidance behavior scores, that you were going to get better no matter what intervention you had. And if you had a really low score in those, that you wouldn't get better no matter what intervention you had. And yet I felt clinically, and I think this is the important thing you're talking about, Adrian, clinically, I felt like I knew that the intervention I was doing clinically, anecdotally, was actually resulting in a shift and a paradigm shift in these clients. And so that was what I wanted to know was, if I create a positive movement experience, can it shift the psychosocial belief, the scores of, what Bandera and Flexner and a couple other researchers were doing up in Buffalo, New York, that they were looking at saying this diagnose adios, which really canceled us as rehabilitation practitioners. It was saying chronic pain, whatever this test says is what it is, and you can't change it. And so we were looking all the time at these physical limitations as our predictive values, for chronic pain. So what's the range of motion? What's their flexibility? What's their core strength? And of course, I was putting all my apples back in the early 1900s into this idea of core strength, from the idea of how Pilates had sort of fallen into a core strengthening exercise, which we know better than that. But the idea is that when we started really looking at the data, we realized that the outcome of the physical limitations got better with these patients, but they had no correlation with functional outcome. And the psychosocial had an 80%, a 77% correlation with the functional outcome. And we had an N of 93 or 98 or something, so we had a pretty good number. But it was so impressive is that we did see the strength and the range and the mobility and those things get better because they were conditioning and exercising and moving. But the correlation was in the belief and the expectation that they had from the positive movement experiences or those kind of things. So for us, that really shifted the way that I looked at things clinically because I realized that it wasn't all about core strength. And then we can talk about that a lot later too. It was about successful movement experiences when they couldn't have successful movement experiences before. And all I could think of listening and getting into some of your literature and Lorimer's and David's stuff a little bit right after that in 2000 was thinking of, man, if I had these stories to tell, if I had more information to be able to educate them on this as part of it, what would that have looked like? What percentage of success would we have with those chronic pain patients? And I think that is, like you said, it's like the lifelong learning. We keep asking the question, we keep reading the literature. I think that's the key thing is, you know, we have to keep being literate in our literature in the sciences to be able to do that. So I appreciate both of you bringing that up. There's another question on the table. You both are looking at it, and I'd love Adriaan to take a first stab at this. It's sort of like that de-educate to re-educate that you were talking about in the chat. Amit Younger is saying that the difference between how some people, when they get a diagnosis from an MRI or something, they actually get better because they have something to hang their hat on it. And some, it's better that they don't know. And that's what Amit's asking us. Any thoughts on that?
Yeah, I think the perfect study would be to figure out what patient needs the MRI and which one does not. The easy answer today is yes, there is a subgroup of patients that if you give them the medical diagnosis with the scan and show it to them, they're going to be better. And there's a subgroup of people that don't need to see it, they don't need to know about it unless there's a major red flag they have that's driving it. Many of us today sitting in this webinar have some pathological issue going on, be it a bulging disc or some stenosis, arthritis, rotator cuff issue, whatever. I think the cool part is that we can really take to the next level. Is we took 100 people today, some of them need to know the diagnosis and some of them don't, and who are they and why are they that way? That's the cool part. That'll be the really cool part, right? And it ties to things like catastrophization, fear avoidance, those kind of things. But Amit, you're 100% correct. For some people it is, some people it's not. I just want to caution that obviously if there's serious red flags, something is majorly wrong with somebody, we need to scan them. There's a bowel and bladder problem, there's neurological deficit or whatever. I just want us to be careful. We're bashing the biomedical model. It has purpose. There are some bad stuff that happens to people that walk around with a fracture unaware of it and they have serious issues. So yes, 100% true. I find it intriguing for some people. An MRI is MRIs have fixed a lot of people in this country. Let me just stop there. I think John can.
Yeah, I'll kind of take a stab at that one. I mean, you know, when a patient comes in with, let's, you know, say a simple backache, and they ask the question, you know, Dr. Childs, what's causing my back pain? The only really totally honest answer is to look the patient in the eye and say, I absolutely have no freaking clue what's causing your back pain. But that's not the right answer to give a patient. But even though it's genuinely honest, it creates uncertainty for the patient, right? Patients generally want to know that something is not seriously wrong with them. And oftentimes they have serious pain and they view pain as being, you know, very linear relative to the seriousness of it all. So imaging in some cases can be used to help reassure a patient. To me, the issue is simply telling a much more positive story. That when they see, somebody made the comment about, you know, the wrinkles on the inside, you know, when they see the wrinkles on the inside of your body in an MRI, that's capturing a resolution that's so, you know, granular that you're going to see anything and everything. It's just reassuring the patient that, wow, look, you have some gray hair inside your body, just like you have gray hair on your head. You have some gray hair inside your body. That doesn't mean you're sick. It doesn't mean that something's seriously wrong with you. So it's just about telling the right story and using imaging to support a positive interpretation of that image versus using all of these, you know, very complicated words that none of us can spell and labeling patients inappropriately.
Can we elaborate on that a little bit more? I'd love to hear from both of you on that idea of, you know, how do we educate the patient in, you know, what kind of language Both of you are experts in the language of communicating this. I think you just made a very important point, John, of how we talk to the patient. You know, again, my feeling always has been very guttural as far as trying to read the patient of what they're, you know, what they're afraid of, what they want, what they desire in doing that. But I think this idea of teaching them and listening to them that you're talking about is so powerful, so empowering to them, to have the confidence they're going to get better. This idea of aging is not disease. There can be disease related to aging, but aging in itself is not disease. And I think that I'd love to hear some more stories that you could share, or language that you use to, you know, help people understand degeneration, for example. I love when people throw out, oh my gosh, you have osteoarthritis, like a 90-year-old, you know, somebody saying something like that. A completely ridiculous statement to make to a patient, no matter what their nature is. But how do we as practitioners work on language to decatastrophize? How do we work on them understanding that aging is a process? I love that idea of seeing wrinkles on the inside or gray hair on the inside is such an amazing image for me. But what are some other thoughts you have?
Yeah, you know, Brent, so I live in the middle of nowhere, Iowa, and a lot of my patients are older farmers that walk in, and we have these conversations every day. I'll ask them straight up, hey, Frank, you know, what do you think is going on with your back? Well, I got arthritis. So he's indirectly told me because I'm older, I must have pain. They tied them together. So I'll sit with the patient and ask him, so Frank, if I had to plot on a graph aging of your spine from 20 to 30, does your back get older or younger? And he'll start laughing like, well, it gets older, of course, Adrian. Yeah, from 30 to 40, older or younger? Well, it gets older. So if we plotted aging and pain, it goes up, right? So as you get older, your back gets older. Well, at what age is back pain the most prevalent? Your audience today would know back pain is most prevalent between age 35, 40, 45, 50. If aging and pain is the same thing, then only old people should have back pain. Then why do 1 in 3 school kids have back pain? And they sit there and they, whoa, now they're questioning their paradigm. I said, Frank, we have phenomenal research that says older people hurt, yes, but they hurt because they don't move. And I can make you move, I cannot make you younger, but aging and pain is not the same thing. And so now we change that paradigm in a very simple, non-threatening way, because these patients tell themselves a story. I'm old, I must hurt. I'm old, I must hurt. I'm old, I must hurt. And you deconstruct that in front of them, very simple, non-threatening. You know, I want to make sure I go back, Brent, and most of our pain education sessions start with questions. Has anybody explained to you why you hurt? No. Oh yeah, I saw the scan, I got arthritis. Okay, so we then take this story and start deconstructing it. So I think people think pain neuroscience education, as an example, is you sit with somebody for an hour and a half, I'm going to talk pain out of you. No, we're having a very simple conversation where I alter your paradigm, where you go, ooh, if I can make you leave the clinic walking out going, wow, so maybe pain and aging is not the same thing. That's cool. Because now it facilitates movement, which is what we really want to do. So that's an example that we would do using real time in the clinic. Yeah.
Yeah, I like that. I like that analogy a lot.
Yeah, I use the wrinkles on the inside obviously quite frequently. I mean, I use the analogy of, when you wake up in the morning, now that I'm in my, almost 50, and I look in the mirror every morning, I mean, it's very easy to notice that, I have wrinkles around my eyes that weren't there 10 years ago. I have to every single morning, I mean, maybe this is too much information, but make sure I don't have like nose hair coming out of my, out of my nose. And I have hair now that grows out of my ears. That's just, it didn't used to be there. But the fact that those interesting things happen on the outside of my body does not convey anything other than that I'm aging, and it's a normal part of aging. And the exact same thing happens on the insides of our body. All of the things that we experience on the outside that we, classify as aging happens on the inside. The only difference is when it comes to the insides of our body, we use imaging to say that those things growing on the insides of your body therefore means something is wrong with you. And it's a desperate and well-intended attempt to help answer the question of what's causing your pain. It's just in a lot of cases, those answers actually cause more harm than good. It is wrinkles on the inside in the vast majority of cases. And to Adriaan's point, yes, there are serious, cancers and fractures and things that we need to be on the lookout for, but that is the vast exception to the rule.
Yeah, I love that analogy. I do want to move into another topic that we wanted to hit today, and that is looking at ways that we can continue to get educated. Adriaan, you mentioned earlier the importance of just staying in tune with evidence-based studies, Cochrane systematic reviews, really being familiar with the literature. What about just as far as, sort of picking a path and a mentor? What are some examples of some mentors that you have used that have really blessed your career and, just you as a person? I think that's really, I'm more interested in feeling the fulfillment in my profession and knowing that, I have a direction. And there are people who have greatly impacted me. Nancy Bill from San Francisco, they're just Carol Davis from Miami. There's just a whole list of people that have been very impactful in encouraging me, even though I'm in a different area of interest, the idea of guiding me. What are some examples of some mentorship that both of you have had that could be a good example to the listeners to think of how they would even pick or find a mentor and how you found that mentor?
How much time do you got?
About 15 minutes.
Man, the list is long. I want to make sure people know that there is a long list of people I could not thank enough today. To answer the question, let me just jump to the end real quick, Brent. It's simple. Sometimes I think those of us that have started our journey or just beginning are so afraid to go to the mentor, the important person on the stage. I have found them to be extremely generous, extremely warm and willing to talk. Yeah, there's a couple of people that's not very kind, but 99% of them are amazing. There's people that I have never spoken to because I hold them in huge regard. I think they're just whatever. And then I woke up to them and they've changed my life. So I would encourage somebody, if there's somebody you follow their research, you follow what they're doing, whatever, don't be afraid to reach out. I get a lot of emails from people like, hey, I just want to say thanks. And I got this, whatever. It's not uncommon for people to reach out. And I think sometimes we put people on pedestals very quickly, and many of them have been we've all been where you are. If you're beginning your career, we all started our career, and I'm only here today because some very kind people were very kind to me along my way. And so reach out, just ask a question. Some of them will say, I don't have time, but 99% will say, how can I help you? Here's a cool article. If you have a question, contact me, or hey, I'm going to be at that conference. Why don't we hook up for a cup of coffee? And that's how these things start, right? It's amazing. So don't be afraid to reach out. I think people are way more kind than we think sometimes. So.
No, I think that's a great answer. When I was, younger and in the sort of the formative phase of my PhD career, what I found to be most helpful was sort of, give before you get. And what I mean by that is, these mentors are obviously incredibly busy. They're involved in tons of different projects. And I just sought ways to add value to that individual's, sort of life. If that meant I was going to be the lab tech that was going to stay in the lab to see 10 more patients in the evening, all of a sudden they're like, wow, like John doesn't, he just says yes. Yes. And lo and behold, you become integral to that individual's, sort of, they're like, wow, if you really want to get something done, you go to this person or that person. And then the mentorship just sort of naturally flows from there. There's a desire to give back from their part, and it's a very symbiotic, mutually beneficial, relationship.
I think that's the key word, that mentorship is mutually symbiotic. I mean, both parties, and not everybody is a match. I think that's important too. And we talk about that quite often. And typically, even people that I've approached and I said, this is sort of my interest, I really appreciate your contribution to the knowledge base. And they'll say, hey, have you ever met such and such? They're doing some research on an area that might be really interesting to you. And all of a sudden there's a pass off, and I, And I respect that, because what, we really, if we're going to provide mentorship, is probably going to be in a pretty specific area of our expertise that we're interested in, for it to be mutually symbiotic, right? So it's going to be, where do we give back? What do we give forward? And how do we have this exchange? But I find that, I could go to John or Adrian and I could say, hey, I'm interested in this. Do you know anybody that's doing any research on this? And they both would say, oh yeah, think of this person, or vice versa. And I sort of did what Adrian just mentioned at the last CSM. I just got the nerve up and I said, I went to 2 or 3 of Adrian's lectures and I was thinking like, I think it's time for me to actually go through. I mean, I've been using this work for a decade or 2. It's time for me to go through and do the training. And I walked up to him in his booth and presented myself and I said, hey, I know you're super busy. Give me a call. I'd like to talk more. And we were talking within a week. And then John joined the conversation, and I can see people in the comment section saying, we need to get together more. We want to hear more from John and Adrian. So this is really good. Let's go ahead.
If I could just add just one brief comment. I know we're coming up on time, but don't discount the value of reverse mentoring as well. And what I mean by that, if you're a young, highly motivated, clinician, don't discount the value that you might have to keep me from becoming the old crotchety individual that is constantly, criticizing new ideas. So what I worry about most as I age is becoming, as a mentor, discouraging to new ideas. It's a natural part of aging. I think we become more conservative and we take less risks. And so I count on younger, highly motivated clinicians to help keep me young, because the moment I become sort of the, not open to new ideas, it is time for me to exit stage right. And I beg all of you to gently put me out to pasture if I'm ever that person.
All right, we got to do a pinky swear right here, the 3 of us. We're not going to go down that road. I think that's great advice. So feel free to come challenge us and keep us fresh. We don't ever want to be stale.
Yeah.
That's great advice. Let's finish up with the last thing that I wanted to bring up, and that was sort of the societal norms. We've talked about a little bit already. John, you mentioned the idea of the biomedical model. We obviously have the pharma model, which, it's like I go to these chronic pain conferences to be with some of the greatest leaders in pain, and they're talking about all pharma and implants and all these things they have to do. They're not talking about movement. They're not talking as much about education as they should. We're a smaller group, but how do we navigate in the society? Adrian, you were talking about social media and how it's just rampant with people loading information on there, which is interesting. It's fun to look at. They're beautiful people. They're exercising. They're working with patients. But how do we navigate, maybe the final word of the societal norms? And we're changing so fastly as a society, first of all. But from a healthcare standpoint, how do we navigate these societal norms and the changes that are happening in our profession? And how do we continue to drive this idea of evidence and evidence-based outcomes to be able to, really impact the future of our professions?
Yeah, I think it's happening in front of our eyes without us. We have a new paper coming out, Brent, where we actually looked at thousands of patients coming to therapy. So this is going to probably upset somebody, but we classify them based on being a millennial, a Gen Z, baby boomer, etc. And I will tell you, the younger generation are doing very amazing stuff without our guidance: nutrition, sleep hygiene, mindfulness, relaxation, things that I had to go look up, years ago, like, what the heck is this thing? And so I think society is going to correct us in some ways. The younger, newer generation is becoming way more aware of things that we did not have. And so as we enhance those, like at EIM, we are adapting our training, teaching from, our people moving away from manipulation to mindfulness, relaxation, breathing approaches. And so I'm very intrigued to see where our clients will take us. And they are taking us in a very cool direction, I believe, right now, today, from what I see.
Yeah. John, any thoughts?
Yeah, just I think I'll just be quiet on that one for now, just
Okay.
for the sake of time. I
Yeah,
see one more question. It looks like from Sarah.
Yeah, while you're reading Sarah's question, I was just going to say I'm fortunate to be able to lead the curriculum for St. Augustine's on wellness and health promotion. And it is amazing how even in the last 3-4 years, how the papers have changed and how the students are so much more aware of what we used to call complementary therapies, which now research is showing. And this is something, this was sort of one of our missions in Polestar, was to make it so that Pilates was not considered a complementary therapy. It was TheraX. It was movement, and to see them. And we see the same thing happening now with mindfulness. Mindfulness no longer is a complementary therapy. It should be a streamlined therapy. It should be a streamlined intervention. People who are mindful of their bodies and aware of their bodies heal faster, move better, recover faster, are more sensitive to things that actually are red flags. We can go either direction of being, completely stoic, and we can, their show must go on, and they downplay all the pain, and they have a cancer, or they have a fracture, or they have the pathology that really needs addressing, to the other extreme where, the hangnail stops them from living. And, it's like, I do think that's going to be the key. The other thing that makes me think, and this mixed audience that we're talking to today, the listeners, is, how we interact together. How is it that, a Pilates teacher, a lot of times they feel so intimidated by a physical therapist, just like we might feel intimidated by, like you were talking, a master therapist or a doctor or something, and realizing we really have to communicate. I mean, one of the things we've been working on is an algorithm to be able to say, the Pilates teacher can go through and say, yeah, this is an awareness limitation or a strategic movement problem, mobility problem, not a structural problem, that it can correct with cueing and imagery and things that are in their tool bag. But they can also screen out and go, you know what, this needs to have a physical therapist look at it. There's a real mobility issue here that needs to be assessed. Is it a structural mobility problem? Is there a laxity? And we look at it and we go, it might be something more than that. It might need to have some imaging. I need to have you go see my friend, the orthopedic surgeon or the radiologist, and see if there really is something here that's not allowing you to participate in your life. And so any thoughts on just that idea of crossing the professional lines? Really, how do we teach each side of in each of these professions, how to communicate and realize how important, and I often talk about scope of practice, right? So it's trying to stay within your scope, but understanding, for example, I can see a patient and I can think the best thing for you to do is take an inexpensive Pilates class twice a week and see me once every couple of weeks for education and more follow-up. Becomes a lot less expensive than 3 times a week with a physical therapist that they're seeing an aide and doing exercises with, 1/10 of the quality of attention and focus as they would get with a Pilates or a yoga or gyrotonic teacher, and be able to integrate that. And some people going, well, don't they have to be discharged before they can start their Pilates training? Or shouldn't they be discharged before they go to the mindful therapist kind of thing? And it's like, I don't think so. What are your thoughts on that?
I'll take a brief stab at it. I mean, I spent the first probably 5 to 10 years of my career sort of advocating for the value of physical therapy, sort of almost at the expense of every other movement practitioner out there. In other words, somehow we own all the knowledge. And that was a totally misguided, strategy. The problem of healthcare is so dysfunctional that there's room for all of us who are non-surgical, non-pharmacologic sort of movement practitioners. The need is huge. So becoming more open-minded about the recognizing more of the similarities between what we do as movement practitioners. Yeah, maybe, if you're really focused on Pilates, maybe it looks a little different than what maybe someone who's not Pilates trained would do, but we're all sort of aiming at the same target. And so I think just being more open-minded and interacting, seeking opportunities like this to engage in multidisciplinary sort of forums has really at least opened my mind to, you know, the value of these different movement sort of disciplines, if you will.
Thank you, John. Adrian, I'm going to take a stab at Sarah Edwards' comment there. I see your fingerprint on it, and then we'll wrap up for the day. We'll have lots more in the future.
Yeah, I mean, Sarah's question about movement and mental health, absolutely. Current best evidence for pain includes high doses of movement, and the same thing with mental health right now. Just amazing research tying movement to better health and also physical health, but also mental health, depression, anxiety. I mean, the list goes on and on and on. So a lot of cool stuff we're doing here. And I just want to quickly follow up on John's comment. I get very frustrated. We often fight amongst each other. Well, PT does this and this does this, whatever. We have bigger enemies out there, trust me. And I don't like the word enemy, but I mean, Pfizer right now is not blinking because of Gold Star or EIM. Neither is the American College of Orthopedic Surgeons, whatever. We have bigger problems than one united rehab profession or group that should be binding together. And we have all these little infighting, which is just silly. It's really silly, but yeah.
Thank you for that comment. Thank you both. And I'll finish up with Melissa's comment. I think that the real thing that differentiates streamlined therapy and complementary therapy is research. I think that, you know, if you have an intervention that you believe, or you clinically see the changes happening, you know, if there's a way you can be involved in submitting it to, you know, the rigors of research, is really what often differentiates that. When we show that there's a population that legitimately benefits, you know, Pilates has not necessarily been shown to be better, but it's been shown to be as good in the systematic reviews as other forms of therapeutic exercise. That means that it's streamlined in multiple papers. The same thing with yoga, the same thing with some of these other techniques that are out there. The same thing with manual therapies, the same thing with now what Adriaan was talking about with the education. The research is pouring in, and this integration of what we're talking about of, you know, good practice habits, and we're probably going to see a lot of old ones sort of disappear, you know, as John had mentioned. So I could go on for hours with you too, and I know we promised to let these folks go about 5 minutes ago, but thank you so much. We'll have them back on. I do have Adriaan scheduled for one all about pain. We're gonna do that, I think, in April. And then I'd love to get you know, John and Adriaan back on as we talk about maybe some more topics in the future. So any last thing you want to share with this group before we close it down for the week?
I would just want to applaud you as, you know, part of the Polestar community. Your international reach, your multidisciplinary reach is a huge strength. So kudos to really your entire community.
Thanks, John.
Yep, same here on this side. And just remember, movement is medicine.
Yeah, well, we're certainly looking forward to more collaborations and you know, continuing the exploration of improving health, improving wellness, and we probably need to talk on a different webinar about what you finished up with there, Adriaan, on the bigger enemies that are out there. I have no problem saying that the opioid industry is an enemy to us and to our patients. So there are times, you know, I mean, I've had my Dilaudid after I had my neck fusion for a day, and that was the right amount. And then no more after that. So it's like the education again comes into play. Hey, everybody, thank you so much for joining us today. I can't thank John and Adriaan enough for taking time out of their busy schedules to be with us on the Polestar Hour. Most importantly, be kind. This is a world where it's crazy. I still believe that love rules. And when we show unconditional love and we're kind to the people around us, we hold doors open, we let people get in front of us and we don't hold grudges, you know, we can make a difference. And even with the world as crazy as it is. So have a great weekend and be kind. We'll see you next week for another Polestar Hour. Thanks again, John. Thanks, Adriaan.
Thank you. Appreciate it.